There's no doubt that the new immunotherapy drugs, checkpoint inhibitors, have had a major impact on melanoma, but the fact is that even in the best case scenario, the response rate to treatment, with say IPI and NIVO together, maybe that's 50-60%, with NIVO or PEMBRO on its own, maybe it's 30 or 40%. So there's still a substantial group of patients who aren't responding to treatment. So there's a big issue, I think, for us to try to understand that, try to understand in advance, ideally, who might respond to a particular strategy. I think the immune system's complicated. I think with BRAF inhibitors and BRAF mutations, you can understand from a sort of a theoretical point of view how, if you know that the tumour's got this abnormality and you're targeting it with a drug, then it's not that difficult to figure out in advance which patient you might treat with which drug. But there's so many factors with the immune system. You've got the sort of the level of immunity, if you like, of the person, which will vary from person to person. You've got the immune cells, are they in the right place? Are they doing the right thing? Is the tumour stopping them working properly? So I think for immunotherapy, there's lots and lots of different factors. I think it's dynamic as well, so in other words, it changes over time. And what I would see in the future, and I don't think this is going to be in the next year or two, is perhaps the ability to look at lots of these different factors, and there might be 6 to 8 different factors, and try to almost come up with some sort of composite score, which would give you an idea perhaps of which treatment to use in a certain situation. And it may well be that tumour PD-L1 expression is one of those things, but I don't really see it at the moment as being useful in isolation. It might be one of a number of different factors if you're thinking about anti-PD-1 treatment or anti-PD-L1 treatment.